your seats as we have an excellent and interactive session lined up for you. My name is Harald Jorstad, and I'm honored to present my co-chair, Professor Silvana Molossi from Texas Houston, who's going to co-chair this session with me, which I'm sure will be fantastic. And without further ado, I would like to invite the first speaker, nucleus member of the sports cardiology section of the EAPC, Alessandro Zorzi. Give him a round of applause.
Thank you very much for the introduction. And before starting, I would like to say that exactly 14 years ago, I gave my first international presentation in this exact place. And I would like to thank again the CRY Foundation and Professor Sharma and Professor Papadakis for the opportunity at that time and also for today. So I come from Padua, Italy. If you want to know where it is, it's here. It's close to Venice. So if you want to come and visit Padua, you will also very easily go to Venice. And what Padua is also famous for many things, including the Scrovegni Chapel, the ancient anatomical theater where the first autopsies were performed, and also for Galileo Galilei. But in the field of sports cardiology, what Padua is probably most famous for is this figure. That was published in 2006 by my mentor, Professor Corrado, and the figure that is presented still today in every conference. There has been much debate around it. But what basically this observational study shows was that after the implementation of a mandatory pre-participation screening, so in Italy, every competitive athlete needs by law to be screened every year, we observed a decrease in the incidence of sudden cardiac death in the athletes. So not everybody believes that the reason for this decrease was pre-participation screening. There may be also other explanations, but it is important, and in my opinion not enough underlined, is that in parallel with the decrease in the incidence of sudden cardiac death, we observed an increase in the diagnosis that were made in young athletes, cardiomyopathies particularly, because of abnormalities on pre-participation screening ECG. This is because, particularly for some cardiomyopathy phenotypes like Ockham or arrhythmogenic cardiomyopathy, the ECG is abnormal in the majority of cases. At least it is a majority of overt cases, as those with a highest arrhythmic risk. So this led the European Society of Cardiology and other societies to suggest implementation of pre-participation screening programs based on the 12-lead ECG together with family history and physical examination. And this also stimulated many controversies. Yesterday, we also had, during the ESC Congress, debate about whether routine ECG should or should not be part of pre-participation screening. But honestly speaking, I agree with the perspective of Professor Dresner that talked yesterday, that there is no way we can implement a serious pre-participation screening program based only on history and physical examination. The chances to identify abnormalities based only on symptoms or family history is very low. You should at least have an ECG, and this will increase very much the chances to identify a disease. But of course, not everybody agrees. For example, the American Heart Association perspective is that they recognize the ECG can identify the disease earlier, but also the perspective is that the high number of false positives leads to unacceptable costs for unnecessary further tests. And this is because as we already discussed during the previous session, the artery ECG often is not strictly normal. So probably everybody will recognize this as a normal ECG, but if you apply the criteria for interpretation of ECG in the general population, that would be probably reported as an abnormal ECG. And in particular, when we are dealing with some variants of early reposition than the typical early reposition value on the athlete's heart, differentiation between normal and abnormal ECG may become very challenging, particularly for non-experts. And so to overcome this limitation, during the last 20 years, a series of criteria have been developed and published in order to help cardiologists and other healthcare professionals to differentiate between the athlete's ECG and normal and abnormal. And the last, iteration of this criteria was the 2017 Seattle Criteria International Recommendation that applies a three categories criteria. Green are the normal ECG findings, those that do not require further examinations, versus the red ECG findings that should always be require further examination, and the borderline ECG findings, according to the perspective of the international recommendation, should require further examination if two or more are present in the same ECG. But what probably few people know is the basis for this classification. So we need to take into account disease probability associated with that particular ECG abnormality and the prevalence in the healthy athlete. So if there is an ECG change that show a high prevalence in the normal athlete, but it's very unlikely to be the only ECG abnormality that you can find in a patient with a disease, then it is classified as a normal criteria, as a normal finding. If the prevalence in the healthy athlete is low, so it's not associated with training, but on the other hand, the probability that this is the only sign of a disease is also low, let's say, for example, left axis deviation in isolation, then it's classified as borderline. Finally, if it's not associated with training, so it's low in the athletes, but also it's likely to be the hallmark of a disease, then it's abnormal. So this is the current state of the art. But unfortunately, there are still problems associated with the interpretation of ECG in the athletes that, for the technician, you need to start the video, please. There are false positive and also false negative. False positive, well, we have to say that we are not really concerned about false positive because a low percentage is acceptable and inevitable. So it's, everybody accepts that a small proportion of athletes with ECG abnormalities will require further testing that will result negative. But how can we do to improve it? Well, of course, we need to further refine the criteria based on new evidence, and probably in the upcoming future there will be a new consensus conference to update the criteria. We need to provide better education with events like this one, but also other ones, in order to help interventionists or electrophysiologists or whatever that do not deal with the sports cardiology in their practice, but maybe they see athletes during their private practice. They need to know how to interpret this ECG. And also, I think there's the use of artificial intelligence will help us very much. I don't think at this moment artificial intelligence will become the pilot, but it will be a good co-pilot. For example, yesterday I just submitted to a ChatGPT an ECG of an athlete. Although this ChatGPT is a language model, it is not done for medical purposes, but it provided a very good report, and it did it in 10 seconds. So I think these are technologies that will help us in the future. But let's talk about the video. Let's talk about false negatives that are more dangerous, because if you, think that an athlete has not a disease, but it does, of course it's dangerous. So what can we do? So that was a discussion that yesterday we had during the ESC Congress. Professor Resner rightly said, in my opinion, the question is not whether to perform screening or with an ECG or not, but what else can we do to improve the chances to identify a disease? Well, I can tell you about the Italian experience. We have something different with the other countries because the ECG is repeated on a regular basis every year, and the screening also includes an exercise testing, particularly not for ischemic heart disease in the young, but particularly for exercise-induced arrhythmias. And this is because for some diseases, the sensitivity of resting ECG is quite low. Think about the non-ischemic left ventricular scar, coronary artery abnormalities, catecholaminergic polymorphic ventricular tachycardia. Those are all substrates of sudden cardiac death that usually are associated with a silent electrocardiogram, but can give rise to ventricular arrhythmia during exercise that can help you suspect an underlying disease. With this an example of a rheumatic left ventricular cardiomyopathy with a normal baseline ECG, but arrhythmias during exercise testing, and of course this rare but very dangerous ion channel disease, catecholaminergic polymorphic ventricular tachycardia, that is characterized, as the name suggests, by arrhythmias only during exercise. So what were the results of this screening model according to the Italian law? Well, the fact was that according to the experience of the sports center of Treviso, which is sitting close to Padova, and ourselves, if you perform exercise testing in addition to resting ECG, you increase by 40% the probability of identifying an at-risk cardiac condition, although you need to take into account an increased number of false positives, of course. So it has to be balanced whether it's cost effective. And last year, an update of it was published about the incidence of sudden cardiac death in young athletes in Italy. But the most important point I want to show you is that among the 69 athletes that were identified as having a cardiac condition at risk of sudden cardiac death by this pre-participation screening model, the find is roughly 60% had an abnormal resting ECG, but all the others were identified due to abnormalities during exercise testing. So, in summary, ECG is useful for pre-participation screening, but specific criteria for interpretation of the athlete's ECG are needed. False positive and false negatives remain an issue. And my idea is that if you perform not only resting but also an exercise ECG, the chances to diagnose a cardiac disease increase, as well as, unfortunately, false positives. Thank you very much for your attention.
So if Alessandro can stay close to the microphone just for one more second. Are there any questions from the audience? Or do you still need coffee from after the lunch to get started? Yep.
Can I ask, Alexandro, first of all, I mean, obviously exercise testing is very difficult to implement for most of us, but if you were to implement and try and optimize a protocol that is, I don't know, fairly short, what sort of protocol do you use, or would you suggest people use? Is it a Bruce protocol or something else?
Well, actually, you will be very surprised that the protocol that's suggested by the Italian law is just a step test. Because of the difficulty to implement nationwide screening by a formal pre-participation, formal exercise testing, the traditional practice was to perform a quick 3-minute step test, the maximum effort that the athlete could exercise. But at the beginning, that was done only to assess the heart rate recovery after the exercise as an index of physical fitness. But now that we understood the importance of recording arrhythmias during exercise, this is done with continuous ECG monitoring. So you don't need a specific setting, you just need the possibility to monitor the athlete during exercise. And probably it is suboptimal compared to a formal stepwise exercise testing, but may provide at least a basic screening in order to select those that will require probably further investigation. So this is what is done
Thank you so much. We have one more short question.
Yes, very short. Do you think the difference between the Americans not agreeing very much on the ECG in Italy is related to the African Americans? I mean, you have some amazing athletes in Italy like Mario Balotelli, but I mean, you know, African athletes. But who will, I mean, if people are manually reading these ECGs, not via an algorithm, I can imagine that all the non-native Italian ECGs, many of them will be very abnormal in very normal people.
Yeah, I completely agree with you. I think that, but probably my US colleagues can explain it better than I, that probably the problem was that many African American athletes exhibited repolarization abnormalities that were difficult to tell apart from those of Occam, etc. But thanks to the works like those of Professor Papadakis, etc., we now have much more evidence about the black athletes ECG. And also in these ethnic groups, there are features that can help differentiate between abnormal and normal ECG. For example, the black athletes repolarization changes are confined to the anterior leads, and they are preceded by ST segment elevation, whereas those of Occam usually involves the lateral leads with ST segment depression. So in my opinion, the challenges of interpreting other ethnic variants should not be a reason for, disqualifying the ECG as a useless tool. It's a problem of education, of increase our cultural knowledge. Thank you.
Thank you so much.